Hi, so today we are going to talk about hemolytic uremic syndrome. Now, syndrome is a group of symptoms that consistently present together. Before we dig deep into the group of symptoms, let's talk about the pathophysiology. The main culprit for HUS or hemolytic uremic syndrome is STEC, that is Shiga toxin producing E. coli. Rarely, it can be Shigella dysentery. Now, these bacteria they produce the toxins which cause either diarrhea or dysentery. That is, a patient may not always complain of bloody stools. The patient can also have gastroenteritis, that is vomiting and some abdominal pain. These symptoms usually resolve in few days, often without any intervention. A week following this episode, when the toxin enters the body, it causes endothelial injury of the small vessels. Now, the small vessels, it's very important to remember that involves the small vessels. Now, this causes the whole triad of HUS, which is as follows. If you may recall, endothelial injury is one of the components of the workhouse triad, and hence, the endothelial injury causes platelet plug formation, the first stage of primary hemostasis, which causes platelet consumption, and hence thrombocytopenia, the first component of the triad of HUS. The second component is acute kidney injury, and it's of intrinsic type because this thrombosis, it involves the efferent limb and the glomerulus as well. The third component of HUS is the hemolytic anemia. This platelet plug, it causes occlusion of the small blood vessels, and when the blood passes through, the RBCs are sheared. And this shearing causes the formation of helmet cells or the schistocytes. This also causes hemolysis and hence the hemolytic anemia. So the triad of HUS is thrombocytopenia, which may present as bruising, fatigue, or ecchymosis. Then we have the intrinsic acute kidney injury, which may present as oliguria or hypertension with PUN or create ratio of less than 20. The hemolytic anemia is the third component of the triad, and hence the patient is anemic with pallor and fatigue, and the hemolysis causes icterus. There is decrease in haptoglobin because the haptoglobin binds to the free hemoglobin that is released from hemolysis. There is increase in indirect bilirubin because of the release of unconjugated bilirubin from the RBCs, and finally schistocytes on peripheral smear, as we already talked about. The management is supportive with fluids to maintain the intravascular volume and circulation. Then we have electrolytes balance, blood transfusion in case the patient has severe anemia of hemoglobin less than 6 or 7, and sometimes dialysis as well, because the patients might have sometimes symptoms of azotemia or symptomatic uremia. One of the important things that I would like to mention is if the patient presents with diarrhea or dysentery, and we follow up the patient for the stool culture or PCR, and if the patient is found to have STEC as the cause, then we should not give antibiotics because giving antibiotics precipitates or increases the risk of HUS. In case of Shigella, it's safe to give antibiotics in case the diarrhea or dysentery is severe because it does not increase the risk of HUS. I'd finally like to summarize HUS with this clinical vignette or classic presentation for our question stem. So we have a 5-year-old boy. This is very important to remember. The demographics of HUS is usually of pediatric age group, is brought to the office due to pallor, fatigue for the past 3 days. The patient has been lethargic and inactive throughout the day. On review of some systems, the parent reports that the boy had nausea, vomiting, and diarrhea 10 days ago, which resolved without any intervention after a few days. The boy has no chronic medical conditions. He's afebrile with blood pressure of 120/70. Now, this is not normal for a 5-year-old boy. He's hypertensive and his pulse is 140, which means he's tachycardiac as well. On physical examination, there is a tired appearing boy with some pallor, icterus, a grade 2/6 systolic murmur is present. This is important to remember that a grade of less than equal to 3/6 systolic murmur is often considered benign. And in this case, it will be mostly anemia as the cause as we go ahead. The lungs are clear to auscultation. The abdomen is soft, non-tender, and not distended. The labs have the following findings of hemoglobin of 8.2, platelets of 35,000, and leukocytes of 14,800. Serum chemistry shows PUN of 34 and create of 2.54. So if you calculate the ratio, it will be less than 2. Now, if you may recall, the ratio of PUN to create of more than 20 is classically present in pre-renal azotemia, as the function of kidney is perfectly fine, and hence they are able to absorb more PUN from the urine, and hence there is rise of PUN in the blood. Now, the question stem may ask for diagnosis or management of pathophysiology or cause of kidney injury, which we have already discussed about. The important things to consider here is this murmur not to get carried away by that, and the demographics, which I discussed from this question still. Thank you. That's it for HUS.